Good morning and good afternoon. Welcome to the Foundation for a Smoke-Free World Economics webinar, Following the Science, using the best available evidence to assess the health risks of nicotine products. I'm Patricia Kovacevic, and I will be your presenter today. With me today is a distinguished group of experts, some of which are Foundation grantees. And we will address some important issues. Allow me a few words that describe the logistics of this webinar. First and foremost, most of you available online, we're thanking you for joining us. You will be in listen mode only, and certainly you have the opportunity to ask questions. At the bottom of your screen, if you're familiar with Zoom, there is a Q&A button, and you're welcome to type in your questions, and I will address them to the speakers at the very end of the presentations, because we do have one brief introduction, a presentation, and then a discussion followed by a rebuttal. So please do type in your questions as you think of them, but we will reserve the right to either address them collectively, or perhaps if the time does not allow it, of course, you're more than welcome to reach out to the presenters. Their bios and contact information is publicly available. With us today are Professor Dr. Ricardo Polosa. He is a respiratory physician and harm reduction expert. Also, Dr. Rachel Marquette, who's a project director at Biochromex. I'll tell you a few more words about each of them as I introduce them. And last but not least, Dr. Renee O'Leary, who is a harm reduction literature review expert. Dr. Polosa is going to present an introduction. He is a full professor of internal medicine at the Department of Clinical and Experimental Medicine of the University of Catania, and a very well-regarded Italian respiratory physician and clinical immunologist, allergist, and rheumatologist. The most important part of his activity, of course, is the fact that he's the most prolific author in the field of electronic cigarettes and all kinds of harm reduction products. The center that he founded in 2018, together with 38 academics, it's called the Center of Excellence for the Acceleration of Harm Reduction at the University of Catania. And this is a unique multidisciplinary center. In fact, Dr. O'Leary is also supporting the work of the center as well. And it's really unique. Their work extends over a number of years. Without further ado, Ricardo, please share with us your introduction, and thank you. It seems that we lost Dr. Polosa. Let's give him a second to reconnect. I know he had some connection issues. I will take this opportunity to start introducing the other two presenters in the interest of time. Oh, we have Ricardo back. Ricardo, can you hear us? All right, let's give him a couple of minutes to reconnect. Ricardo? Yes, it seems we have.
I was saying.
Thank you. Please proceed. I'm sorry about the interruption.
What I'm trying to reconnect with another connection, which is going to be stable. Oh, damn it.
If it's more convenient, Ricardo, you may want to take your video camera off and perhaps just share your screen. That could also work sometimes when the connection is poor. All right, so as I was mentioning, Ricardo, while you're connecting, let me say a few words about Dr. Rachel Marquette and about Dr. Renee O'Leary. So Dr. Rachel Marquette, who will present after Dr. Polosa, leads strategic intelligence projects at Biochromex. She holds a PhD in chemistry from the University of Cambridge and has extensive years of experience as a scientific consultant to all kinds of consumer good brands. The presentation she worked on is fascinating, and I trust that you will find it interesting as well. The discussion after Dr. Marquette's presentation will be provided by Dr. Renee O'Leary, who is really a long-standing researcher in the area of tobacco research since about 2006, with the simple observation that tobacco use was the world's leading cause of death. She has focused her research efforts on reducing the harm from cigarette smoking. She has a doctorate from the University of Victoria in Canada with a dissertation on vapor products, e-cigarettes claims and evidence, and has contributed to research since. We have Dr. Pelosa back with hopefully a better connection, so I will turn to him.
Okay.
And thank you for your patience.
And I'll make it and I'll make it quicker so that I'll be excused for my untechnicalities. So, of course, first and foremost, I'm a respiratory physician and also an expert in tobacco harm reduction. Let me share my couple of slides. Ladies and gentlemen, the health risk of cigarette smoking is very well known. There's no doubt about this. And in this, there is, in my opinion, a very clear correlate, a link between, you can see top on the right, a packet of cigarette, and top on the left, the lung cancer. So there's a clinical radiological link between cause and effect. Let me just go to the next slide. The key is to avoid this exposure. And to avoid this exposure, deadly chemicals, of course, will end in a reduction of smoking-related disease. What do we do? One option is, of course, to engage in smoking cessation programs. But besides smoking cessation programs, the avoidance of combustion is key. It's key and can be achieved via cigarette substitution with combustion-free alternatives. Why is that? Because combustion-free alternatives, one of the problems we have is that we don't have direct confirmation of the public health gains or the health gains that they may derive from substitution. Here in these slides, you have an example, and the example is snus. Snus, maybe some of you don't know, is an oral form of tobacco smokeless here that is being commonly consumed in Sweden for more than a decade. And this has led to, I would say, pretty extraordinary public health gains, as you can see in these slides. So consumption of snus results in the lower prevalence of lung cancer mortality amongst all European countries. Okay, unfortunately, direct confirmation of the benefits of smokeless and combustion-free alternatives is not possible with the electronic cigarette and heated tobacco product today. Nonetheless, there are other alternatives, other approaches, for example, quantitative risk assessments or population modeling that can provide a confirmation of the substantiation of risk reduction potential of these combustion-free alternatives. And these approaches have been recommended by FDA and by many authorities worldwide. So it is my pleasure to introduce to the next presenter of today's. I'm sure she will present you with her approach to try and substantiate the risk reduction potential of combustion-free alternatives.
Thank you, Dr. Pelosa, and indeed, thank you very much for the wonderful introduction. And indeed, our next presenter is Dr. Rachel Murkett. Dr. Murkett.
So thank you very much, everyone, for joining today. In this webinar, I'm going to be talking about using the best available evidence to assess the health risks of nicotine products. In particular, I'll be talking through the nicotine products relative risk assessment systematic review that I, with my team at Biochromex, published in 2020. First touching on the context for this study, then the methodology, results, and briefly how they fit into the bigger picture. So this is just to give you an impression of the agenda for today. So as I mentioned, we'll be first walking through some context, and then the evidence landscape, the relative risk hierarchy, and putting this into the bigger picture of health risks with harm reduction in mind. So moving into the content here, to give some context, when we talk about nicotine products, we're in fact covering several product sectors. So we have tobacco products, which include cigarettes, pipe tobacco, cigars, etc. We have non-tobacco products like non-tobacco nicotine pouches, electronic cigarettes. And then we have pharmaceuticals such as nicotine replacement therapies. So the use of nicotine products across these sectors are closely associated with public health, some due to their harmful effects and some due to their beneficial reduced risk profile. Internationally, as alluded to by Professor Pelosa, there is a widely recognized and urgent need to end the use of combustible tobacco products that have been proven beyond any doubt to cause increased risk of disease and mortality for their users. Combustible tobacco has been estimated to cause more than 8 million premature deaths globally every year. The toxicity of these products is due to the emission of toxic chemicals during combustion. So tobacco smoke is known to contain over 8,000 chemicals, of which 250 are known to be harmful and 69 are known to be carcinogenic. Over the last half century, several alternative forms of nicotine delivery have been developed, which reduce the user's exposure to noxious byproducts. These new or next generation nicotine products aim to reduce the harms associated with traditional combustible forms of nicotine consumption and give users a way to immediately reduce their health risk while breaking their habit of tobacco use and weaning off nicotine gradually. This is known as the harm reduction approach and focuses on reducing the risk of adverse health outcomes rather than focusing solely on abstention. So these alternative nicotine products are often referred to as modified or reduced risk, and they're undergoing rapid development and evolution, both in terms of the design of the products and devices and what we know about them in the scientific literature. The scientific literature on nicotine products is growing rapidly, particularly for the newer product categories. For example, 10 years ago, if you conducted a search of electronic cigarettes on PubMed, you would get 165 studies. If you conducted the same search today, that returns almost 10,000 studies. So we have a literature that's growing quite rapidly, and there's a lot of information being published about these devices. The challenge really is how to gather this information, assess it scientifically, and put it into the context of other available nicotine products, public health, and harm reduction in such a way that enables us to accurately inform strategies that improve health outcomes for the population. So public health decisions draw on scientific literature to guide evidence-based recommendations. These recommendations can have enormous implications for the general population, and it's widely accepted that the best quality science, in other words, the most objective and reproducible, is forming the backbone, should be forming the backbone of our knowledge. However, the scientific literature by design includes a wide range of study types with an equally wide range of certainties attached to them due to varying levels of methodological rigor. You have expert opinions, single case reports to cohort studies, from small samples to population level samples, and so on. This is a key part of the scientific process, which allows scientists to share ideas, critically appraise, and further develop the ideas that stand up to scrutiny. But not all published literature is suitable for real-world application. So this is where systematic literature review comes in. Systematic reviews provide a methodological approach to gathering scientific literature while eliminating the possibility as much as possible of study selection bias. Furthermore, there are a number of accepted frameworks in place that outline the best practices for systematic reviews. This enables researchers to maintain a high standard of methodology and standardized methodologies across different systematic reviews. And some of these frameworks include Cochrane, for example, or Prisma, which is the preferred reporting items for systematic reviews and meta-analyses. Prisma lists all the checks and controls that should be included in a systematic literature review to make it as free from bias as possible. For this reason, systematic review is the gold standard approach to synthesizing and assessing scientific literature. Of course, a systematic review is only as good as the studies it includes. For this reason, the Prisma and many other checklists contain assessments of study quality within their methodology, looking at study design and objectivity. This is also often referred to as a risk of bias assessment. It's this that helps us to select the best available evidence objectively. So, as I mentioned, numerous frameworks have been developed to score scientific literature based on their methodology. One of these frameworks is the Oxford Centre for Evidence-Based Medicine ranking system, which is what we used in the nicotine products relative risk assessment. This system prioritizes studies based on their design, objectivity, and reproducibility. So, as such, we have randomized controlled trials and cohort studies, which are allocated the highest priority, with systematic reviews of each study type being prioritized above single studies. This prioritization between systematic review and individual studies across all the categories, the first three categories, reduces the chance that you get anomalous or irreproducible results from a single study guiding the entire literature review. At the other end of the scale, we have expert opinion, theoretical papers, and case reports, which are given the lowest ranking due to the lack of methodological control, the high risk of subjectivity bias, and the lack of reproducibility. So when referring to studies in the scientific literature, it's important to stress that single studies represent only a piece of the jigsaw, and reproducibility of a result is imperative to identifying real trends and discoveries. Systematic reviews allow us to gather the scientific literature objectively using a predefined methodology to assess the strength of evidence, the relevance of the studies to the objective or the question of the review. And with meta-analysis, we can then identify reproducible trends that are supported by several studies in the literature. By selecting high quality cohort studies or RCTs over lower categories of evidence, we can reach more objective and accurate conclusions based on the available evidence. So this was the idea behind the nicotine products relative risk assessment. We wanted to gather and assess the scientific literature on a wide range of nicotine products as accurately and quantitatively as possible, and establish what the relative risk of each product is within the context of the full spectrum of nicotine products. Our risk assessment included 13 nicotine products, which are shown here on the slide, ranging from combustible tobacco to smokeless tobacco to heat-not-burn devices, electronic cigarettes, non-tobacco pouches, and nicotine replacement therapy. Previous work in this space had derived spectrums based on esteemed expert opinion or used quantitative methods such as modeling of toxin emissions to assess smaller categories of products. So what we wanted to do was to combine these ideas and expand the methodology to include as many products as possible. The end goal essentially being to derive a spectrum of risk based on the best available evidence from the scientific literature. So the Prisma diagram that you see on the right of this slide is a key component of systematic literature reviews. Effectively, it summarizes the outputs of the literature search, the number of studies at each stage of the protocol, and the reasons for the exclusions of those studies. In the nicotine products relative risk assessment, we had over 4,000 studies which were identified across the literature searches and bibliographical searching of reference lists. The studies were screened at the title, abstract, and full text level. During screening, over 3,000 of studies were excluded for the reasons you see listed on the right-hand side of the diagram. Our inclusion criteria focused on studies that reported on the health outcomes of primary exclusive use of a single nicotine product. Overall, we identified 320 studies that fit the criteria for inclusion and 53 that were eventually included in the meta-analyses that I'll go into a bit more detail on in the next slides. So just to put a note on our selection of the best available evidence, due to the abundance of the literature in certain categories of nicotine products, we were able to narrow our search to only the top categories of evidence in the Oxford Centre for Evidence-Based Medicine ranking. Of the 320 studies that were shortlisted to have met the inclusion criteria, only OCEBM categories 1, 2, and 3, that's to say, only RCTs, cohort studies, and high-quality case control studies were included. The included studies were further prioritized based on their evidence category as well. For example, if we had several studies reporting on the risk of oral cancer development for chewing tobacco users, including a mix of case control and cohort studies, we only included the high-quality cohort studies. If we had several cohort studies, we conducted a meta-analysis of the cohort studies. So when we talk about the health risks of nicotine products, this is obviously a broad statement that warrants further specification. The health outcomes included in this analysis are listed here on the slide. They include 22 cancers and 19 non-cancer outcomes. The cancer outcomes cover head and neck, lung, gastrointestinal, reproductive, and blood cancer, and the non-cancer outcomes include cardiovascular and respiratory diseases. So this slide shows briefly what the inputs for the relative risk hierarchy were. Essentially, the main input for the risk hierarchy was the combined risk score. This is a very brief overview. There's a lot more methodology behind this, so I would encourage, if you are interested in finding out more about exactly how these were calculated, taking a look at our paper online, which is open access, which has full details of the methodology and the equations that were used to calculate this. And so in the calculation of the combined risk score, this is where we deviate slightly from a classical systematic literature review, which would look at one health outcome for one exposure or one intervention. And generally, it would use systematic reviews of randomized controlled trials, whereas our goal was really to capture as broad a spectrum of nicotine products as possible and as many health outcomes as possible to give a high-level overview of the risk spectrum for the nicotine product categories. So in order to quantitatively plot the nicotine products on a continuous risk spectrum, we derived a combined risk score for each product based on the toxin emissions and toxin content data, which gave us lifetime cancer risk estimates and epidemiological data. So the toxin emissions that included 12 IARC Group 1, which are known carcinogens for inhalable products, and 5 Group 1 carcinogens for ingestible products. These were extracted and fed into the lifetime cancer risk analyses. So the analyses that we used were based on previously published literature that had developed these methods and the FDA standard for smokeless tobacco products. For the epidemiological analysis, we extracted the available odds ratios for each disease state, and we included only diseases that we had data from 3 or more nicotine products, and this was to maximize the comparability of the values between the products so that we weren't comparing very different profiles of disease states for one product against completely different profiles of disease states for the rest of the products. We wanted to make sure that there was a level of consistency between exactly what the combined risk score represented for each of the products. This was, of course, a trade-off between the completeness of the data and incorporating enough data and the number of products for which we had data. And so we set this at 3 or more. The combined risk scores were derived from these data sets by setting combustible cigarettes as 100 and non-nicotine product users as the 0 point. Combining the 2 data sets, this gives us the risk score. So plotting the combined risk score against the nicotine product category gives us the relative risk hierarchy. This is shown here on this slide. The percentages listed in the x-axis show the data completeness for each product. In other words, how many of the data points were available for that product compared to others. This is also an important component of the Prisma checklist, because this tells you where there may be error due to missing data and the risk of bias because of the data completeness. So it's an important value to keep in mind. As you can see here, the combustible tobacco products occupy the top of the spectrum from 100 down to 41. They sit significantly higher than any of the other categories of products. We then have dipping and chewing tobacco with scores of 15 and 11 respectively. Heat not burn devices and snus, which both sit just above 3. And the rest of the products, the non-tobacco products, sit below 1. And their respective values are shown there on the graph. So based on this analysis, we conclude that combustible tobacco products are the most harmful nicotine products by a significant margin, followed further down the scale by smokeless tobacco products, with heat not burn devices and snus occupying a lower tranche of the spectrum, followed by the non-tobacco nicotine products, which don't have a significantly elevated risk above non-nicotine product users. So again, this is a key requirement of the Prisma list, which is to discuss firstly the conclusions of the study, and then to discuss the limitations, which is going to tell us where the knowledge of our study ends and where we can't draw any conclusions. These are just 4. There's a full discussion of this in the paper, so again, that would be the best place to get the complete information. But firstly, I wanted to highlight that we deal here only with exclusive use of one nicotine product. So dual use, which does occur in the real world, is not accounted for here. This is by design, and it's part of the methodology. We only looked at data for exclusive users and we didn't include analysis in the toxin emissions of mixed use of different products, just to try and make the data as comparable as possible, and show a real representation of the risk of each product individually. Secondly, we only look at the primary use of nicotine products, so we don't go into second-hand or third-hand exposure. We really did focus just on the user of the nicotine product and what the risk of health outcomes for them is. Thirdly, the risk hierarchy looks only at health risks, so we don't incorporate any data on efficacy for smoking cessation of the newer products. We don't incorporate any sort of efficacy analysis, and this really is looking at the risk side of the equation. It's also important to reiterate that we are dealing with the best available data. So while we've done everything we can to select the highest quality of studies and make the methodology as objective and in line with guidelines as possible, we don't have 100% of the data points for all the products, just simply because there are gaps in the scientific literature. So lastly, I just wanted to finish by putting this into some context. So overall, it's important to use a methodology-driven assessment to examine the health risks of nicotine products. This allows us to maximize objectivity and avoid potential bias, focusing on the best available science and what it's telling us. In turn, this allows us to develop better strategies for tobacco harm reduction, which will produce better health outcomes for users, and overall, following the science, using objective and reproducible analysis of the best available evidence combined with pragmatic approaches to harm reduction will logically deliver the best results. Thank you. And finally, I wanted to just thank the Foundation for funding this research and my co-authors and colleagues at Biochromex for listening to the project.
Thank you very much, Dr. Murgett. And allow me to remind all of you that this webinar is recorded and will be available on YouTube and as a link on the Foundation website in due course. So if you wish to revisit it, of course, or to share it, that's definitely going to be possible very soon. And we already have 3 questions, but as promised, we will wait until the end of the presentation by the 3rd presenter, and will allow Dr. Murgett a brief rebuttal time. So I'll pass the microphone and camera on to Dr. Renee O'Leary, please.
Thank you, Patricia, and thank you everyone for inviting me here today. See here, share my screen and go to the slideshow, start from the beginning. There we are. So again, thank you. This is my first time being a discussant for a webinar. So I asked what I should do, and the reply was that I should discuss the methodology of the paper and provide feedback that improves it. And since that's what I do with my reviews, I applied the AmStar 2 checklist. And I do that because I believe that standards are better than just opinions. AmStar 2 was first published in 2007. It's one of the most widely used tools around. It was updated in 2017. It's been used thousands of times. So before I start, let me emphasize that my comments are about the paper, not its authors. I do trust in the integrity of my brother and sister researchers. I respect their many years of education, their experience and dedication. I have given these recommendations to the authors, and it's up to them to take whichever ones they wish. All right then, it's about the dish, it's not about the chef. So let's get on with AmStar. The first question is about the structure of the research question. It does not really apply to this review because it's not an analysis of medical interventions, so we'll skip it. Next AmStar requirement is a protocol. A protocol is a pre-specified research plan, much the way that an architect shows you how you're going to build your building. It's important to have it so that you can have consistent results, that things are reproducible. So this is why we do protocols. It also makes sure that you're not adding something in just because it looked good later. And I promise this is my only all caps recommendation. Inclusion is the next question. Did you explain how you included studies? Yes, this paper does a very good job at that. It's a full description. My only recommendation was I saw this beautiful inclusion-exclusion table in the online files. I think it would be a real addition to the actual draft of the manuscript itself. Next, we ask about the search. A high-quality search for studies has many requirements. One of the more important ones to me is to check the reference list of the included studies. I've always found additional studies this way, more obscure studies, things that aren't indexed, things that were missed in an index, happens all the time. I think that they might have done some in this because when you look at that Prisma diagram, besides databases, there's a list of studies that were found in other ways. At any rate, it's always good to specify what you actually did. Next is the idea of dual coders. I was not really clear from the report whether they had done dual coders. Why do we do dual coders? Because one person might have missed something or have a different opinion of what's going on. So I always, in my reviews, have two reviewers independently do each of the selections and compare their notes, but you also can just do it by a sample. It's very important that you, there's not any errors in a missing. If you have just one person and they're working late at night and they accidentally put excluded when they should have included it, it's nice if someone else is already there checking on it for me. Dual coders is also used when we talk about the data extraction. That's when the team goes and looks for the data in the studies that they're using. There's really no way to double check this again, but you should always state how your data extractions were checked for accuracy. Transcription errors happen. When I review studies, I sometimes have to contact the study authors and say, did you mean this or did you mean that? Particularly when there's two different numbers. It does happen. It's good to be checked. Next, the AmStar asks you to put in a list of the excluded studies. That would be pretty long for this review, but the reviewers did report exclusion reasons for the studies overall, but not individually. It probably would be a good idea to put a list of excluded studies in the online files, not in the main paper, because the readers want to know which studies you evaluated, and authors want to know, did you check my study? Next, we look at the study details. We want to know a little bit about the studies. This review is a little different in that the studies are referenced as citations in each risk category, but there's no study table. I'm so used to seeing study tables, they're pretty standard. So it only takes a little bit to list all the studies in the meta-analysis. And if there's not room in the journal article because of the time, you can just go ahead and put it in the additional materials file. Next is the risk of bias assessment. Risk of bias is a measurement of how trustworthy the data are based on how the study was conducted. There are many checklists to assess risk of bias. You pick the ones that work for you. Risk of bias assessments of the individual studies are a core component of systematic reviews. Unfortunately, many reviews skip it. It's time consuming, but it does add to let you know, was this a good, strong study or was it a weak one and we're using weak evidence? I've recommended to the reviewers that this be added to their work. Next, the AmStar 2 says, please talk about the sources of funding for the studies in the review to see if there's any conflicts of interest that could lead to bias. I recommend that in that study table, you identify the funders, tobacco and vape industries, pharma, any place else you think might be a risk of bias. We have to remember this is a very contentious field. Many researchers will automatically exclude industry studies or they'll segregate them. So it's important to identify them in the review. Next, they ask about the meta-analysis. Did they use appropriate methods? This was very well done in this paper. I have absolutely no comments. Good job. Well done. Next, we check for what's called heterogeneity. This is a big scientific word, and it's the term for the range or size of variation between the studies. It can be very different outcomes in the data. But it also could be that the studies each have been done with very different participants, such as young people for some and older people for others, or the studies could have been conducted over different lengths of time, some over weeks and some over months. So a rigorous review is going to check for how the heterogeneity could affect the findings. This review did make one specific reference to checking for heterogeneity, and they reported it as the reason for the exclusion of the biomarkers. I absolutely agree with this. Biomarkers are very difficult data to work with and are quite heterogeneous. Next, Amstar asks if you checked for publication bias. Publication bias is a very technical analysis to see the pattern of established findings in the studies. Now, the major reason we do this is because studies that find no significant changes or differences, which we call the null hypothesis, have much less chance of being published. And finally, did the review authors report their own conflicts of interest and the funding they received for the research? This has been done, and I'm done too. Thank you.
Thank you very much. Appreciate the comments. We'll give Dr. Merkett an opportunity to answer. But in fact, in conjunction with her answer, perhaps I can turn to a couple of questions as well, because they're directed to you. So let me present the questions, and then perhaps Dr. Merkett can try to address them at the same time with her rebuttal. One of the questions, in fact, also was mentioned, or reference to the topic of that question was done by Dr. O'Leary. So the question is as follows. You mentioned that the number of studies of harm reduction products has in fact increased, but could you please be more specific about who is funding these studies? I'm sure you must have looked into it, perhaps it didn't make it into the review. Another question asks about how does epidemiological data from countries over long periods of time, such as Sweden, SNUS, fit into the analytical framework you're using? Also a third question, and again, I leave it up to you if you wish to address them in a particular order. The question was whether dipping and chewing tobacco shown in the chart of the US variety are the same, or are they separately, distinctly addressed? And given that the US and Asian style oral tobaccos are different, if they were to be combined, could you draw some inferences, or if they weren't combined, could you draw some inferences? And finally, a very complimentary comment, but also a very honest question. The participant asked, when one goes to Google Scholar and looks at your article, one can see very few citations to the work, which is very valuable and very thorough. Do you have a sense why the work is not being cited by other researchers? So, Dr. Merkett.
Thank you, Patricia, and thank you to Renee, and thank you to everyone who submitted questions. So I just wanted to comment on Renee's analysis of the work. Again, to reiterate, thank you so much for taking the time to do this Amstar evaluation of our study. We're big supporters of open science, and we made every effort to be open and clear about the protocols used in the study, as I hope I communicated during the presentation. We of course welcome feedback and criticism, and this is also, as I alluded to in the presentation, an important part of the scientific process, and it helps us to develop better studies and better conclusions and improve our work. So it's incredibly valuable to have this sort of feedback. I did just want to highlight the point that I think Renee had on her second slide regarding the Amstar tool, which was developed for primarily for systematic reviews of RCTs for health interventions. So for that reason, I think some of these components are not directly applicable to the type of review that we did, and I think that you did call that out in a number of the slides. And also we did, as I mentioned during my presentation as well, we did use the Prisma checklist. This was the 2009 version, which was the most current at the time when we were doing our review. And this has been submitted in the extended data. So I did just want to call that out, that we did use one of these frameworks to assess the quality as we went through and ensure that protocol was followed. Nevertheless, I think that was very useful feedback, and we'll definitely sort of take that on, and we've had conversations about this offline as well. So it's extremely useful to us and very valuable. Yes, I think Ricardo would like to add something.
To be honest, I was very relieved and happy to see that the findings of your work are just in line with our 2014 multi-criteria decision analysis that we published in that year. So despite all the struggle around these combustible-free products, the end message, the take-home message stays the same. However, the real question is, and the problem I personally have as a scientist with all these massive proliferation of systematic reviews, is that in the end, they tend not to be extremely informative, because you see for yourself, the literature is now filled with systematic reviews saying exactly the opposite of what you're saying, or what I just said in 2014. And I really was wondering whether, because there's a mass of systematic reviews and meta-analysis on similar subjects, whether there is any space for a meta-analysis of the meta-analysis.
Yeah, I think that's a good point. We do. This is indeed why we have a lot of standards and frameworks, because there's so many systematic reviews coming into the literature, and there has to be some sort of control of the methods. I think that really the goal of our work here was to try and be as broad as possible in what we were representing. So we wanted to develop this spectrum that existed elsewhere, but without such a quantitative focus on the way that the data was developed and the way that the products were placed on the spectrum. So I think that really that was the goal of this, and the best way to get to a quantitative result was to, without sort of cherry picking data, was to do this systematic review and meta-analysis, which allowed us to take a methodological approach to developing the spectrum.
I just wanted to note that there is a methodology for comparing systematic literature reviews. They are called umbrella reviews. And it's a fairly new methodology, only really started in about 2017. I did a little work with them. Well, I did a lot of work with them in my PhD dissertation. So there are ways of comparing the systematic reviews and why the results of one might be more believable or trustworthy than another. But that's a whole nother topic for another day. Thank you.
Yeah, but, you know, this is also a platform for discussion, and let's try to be constructive, because we want to advance the scientific agenda. René, this is a good possibility for you to place an RFP and propose the umbrella review, because there are now so many systematic reviews and meta-analysis about the same subjects going different direction, that we really need to have some clarity on this very thorny topic. And I'm glad this point was raised, so that at least we have an idea, not just for you, also for all these people that are listening to us right now, that the possibility of a serious, high quality umbrella review is on the horizon.
Thank you. Very valuable suggestion. We do have one more question that in fact goes back to the source of funding. The question says, unfortunately, when it comes to anti-tobacco harm reduction propaganda, it is about the chef, not about the dish. That is, tobacco harm reduction researchers are sometimes accused of being funded by tobacco companies, as if this in itself somehow tainted the results of the work. The question to all of you really is, how should researchers respond to such accusations? And I would add, should they respond, or should they even do anything about such accusations? Who wants to take a stab at it?
I can weigh in on that. I think that this comes back to really the scientific method is about reducing bias, regardless of who does the research. It's about making sure that bias isn't in there and getting objective results. So if the science is good, it shouldn't matter who the researcher is. And this is the whole point of the scientific method and why we do things in a methodological way. And so I think that it's understandable that there are some concerns, but I don't think that this is, we should just ignore science that comes from one source or another because of that source. It's a very unscientific way of looking at research, and the best thing to do is really to look at methods and critically appraise based on that.
For sure, and in fact, organizations, government organizations such as the Food and Drug Administration indirectly validated the value of industry-conducted science by authorizing products under the pre-market tobacco application pathway for sale in the US based on a review of the scientific evidence provided by the tobacco companies, but also, of course, FDA conducted their own independent review and looked at other science as well. So certainly, you're absolutely right. There are institutions out there that do avoid bias in those manners. Ricardo, would you like to add to that?
I really think you hit the nail there. Even during the regulatory process leading to marketing of these products, tobacco companies have to produce high quality and high masses of toxicology, epidemiology, clinical behavioral data. And I think that is the path. The path is science of the highest quality. And the problem of conflict of interest may only touch upon interpretation of some of these data. So when there is a clear declaration of interest, any over-joyful of over-the-board interpretation of high-quality data needs to be reframed in relation of a transparent declaration of conflict of interest. So to cut a long story short, good quality science wins in any case, regardless of the source of funding.
And I would add, I came to academia late. I came from a business background for 18 years. A business, when they conduct research, is doing it for the purposes, in many cases, of avoiding litigation or showing the safety of their product. It does the tobacco industry or the vape industry or the pharma industry no good to try and juggle the figures. It doesn't, is not going to do any good for them, and it leaves them open to risk. The other thing is all funders, or at least all funders I'm aware of, have a hands-off policy. They hand you the money and off you go. For the work I've done with the Center of Excellence for the Acceleration of Harm Reduction, I independently submitted the project I wanted to do. The funders, foundation said, this looks good to us, and off you go. I haven't heard peep from them since then. It's all up to me to do the research to the best of my ability. They have no influence whatsoever on how I conducted my study, how I set up my study, or the results that I'm publishing.
Thank you, much appreciate.
Yeah, just expanding on the other side of the trench, we should not forget that unfortunately many academics just do the work for their CVs, for the sake of their CVs, and by doing so they are seeking more and more funding. You know, publish or perish is a culture that is very much embedded in the US research environment. And in my opinion, it is not good because it is not entirely independent.
And indeed, one of the main funders, in fact, is the government to a lot of this research, as we well know, and that obviously is quite important to highlight. Just for curiosity, Dr. Pelosa, you may have been a recipient of government funding in the past. Were they hands off, or perhaps Dr. Murkett or Dr. O'Leary? I'm just curious how that worked.
Yeah, I've received government funding before, and in general, yes, I found that they were relatively hands off, except of course wanting to report results to make sure that the expense was justifiable, which is normal, to make sure that there's some kind of tracking what the funding is being used for. But yes, my experience was much the same as any other funding, that it's generally quite hands-off.
Very encouraging.
I did want to mention one thing. Just because you see a declaration of interest, it doesn't necessarily mean that you found them all. When I was looking at who was funding the anti-vape studies, I noticed that the researchers often said, oh, no conflict of interest. And for example, in one case, I noticed that the researcher has a position as a director on the American Academy of Pediatrics and was making a 6-figure salary. And their legal position was that all vapes should be banned. So just because you've looked for conflict of interest doesn't mean you've always found it. Sometimes you have to dig a little further.
Thank you.
Yes, of course, we received major governmental funding and funding from the European Commission. To be honest, we've been just subjected to administrative control, and there was no intention of manipulating our scientific drive. What I was saying before is that it's us, academics, that sometimes we are very much egocentric, and we tend to to drive the science to a direction where it's most likely to get more and more funding from governmental agencies.
Thank you, and appreciate the closing comments. We have reached the end of our webinar. I wish to take this opportunity to thank again the presenters and in particular the participants, the audience, for joining us at various time zones. This is just one of a series of webinars, so please stay tuned for future notices. We hope you will be able to join us again. Thank you, Dr. Murkett, Dr. O'Leary, and Dr. Pelosa again, and looking forward to seeing you all in person at various events. Thank you. Have a wonderful day. Goodbye.
Thank you very much for listening to the webinar on following the science using the best available evidence to assess the health risks of nicotine products. So regarding the funding of harm reduction studies, I don't have a complete analysis of the numbers up to today. The 10,000 I mentioned in the presentation was just from a quick search of PubMed. We did collect information on conflicts of interest when we extracted the data for the study, but I should say that we didn't go further than the declared conflict of interest statement on the publications. So based on the information that we did collect, it seemed like most of the studies are coming from academic institutions without declared conflict of interest. 3 of the studies we assessed in the 2020 review were published by researchers that had received funding from smoking cessation therapy, e-cigarette and/or tobacco companies, and 1 was published by a researcher at Altria. It's also important to point out that we only had toxin emissions data for the newer products. We didn't find any epidemiological studies for these. And the most comprehensive data sets for this type of data is often collected and published by the companies who create the products as they're required to submit it for regulatory purposes. Regarding the epidemiological data from Sweden and the snus products, So we use this type of data on Swedish snus in the epidemiological analysis component of the framework. So it is represented in the RRH. We prioritized prospective cohort studies when they were available, as this was the highest level of evidence for epidemiological studies, and systematic reviews of epidemiological studies wherever they were available, and meta-analyses as well. We only included studies that clearly delineated the smokeless categories, because we did come across a lot that just dealt with smokeless as one sort of large category, and also studies that adjusted for smoking of combustibles as well. I hope that answers the question. In terms of the dipping and chewing tobacco categories, and the US versus the Asian style, we excluded all categories of Asian smokeless tobacco products in this review. So the dipping and chewing tobacco categories represent only American varieties. It is a priority update for future iterations of this review to add in a category that represents some of those Asian varieties as well. In terms of the Google Scholar citations, thank you very much for this comment regarding the study. I don't have an answer to that question. I suspect it's because we're waiting for a second peer review of the study. Currently, the study's been reviewed and approved by one reviewer. Since then, we've submitted a number of suggestions, but we've been unlucky that the majority were not available. Potentially, the pandemic's played into this because we did publish in 2020 when obviously the journals were very busy prioritizing COVID research. So that may be a factor, and people's disruption to people's schedules and that kind of thing. But that's just speculative. I'm not sure. In terms of the final question here regarding anti-THR propaganda, I do understand that this is a concern about the funding of the studies and big tobacco, and I can completely see the reason for skepticism and distrust around the research. At the same time, I don't think it's reasonable to expect that we'll advance harm reduction or even complete cessation of tobacco products without including the organizations that are making the products in that dialogue. My opinion is that it's far more constructive to have all parties at the table with, of course, a healthy dose of critical thinking and pragmatic skepticism, and pool everyone's resources towards a positive outcome, i.e. improved health outcomes for users. I think that it's important to question the motives of the tobacco companies and definitely to keep a close eye on their actions, which is where tools like the Tobacco Transformation Index are very valuable. But I do think that we're seeing improvements in the actions of these companies, and it would be a shame to block the process of harm reduction and prevent people from having the freedom to access these products that reduce their risk of poor health outcomes. Essentially, I think we just have to remain focused on what the science is telling us and be open to all possibilities.